So welcome to this breakout session. I'm going to be talking a little bit about GU cancers and immunotherapy for genitourinary cancers. What I'd like well, here's first of all my disclosure slide. So what I'd like to really discuss with you is the outlook that we have for GU cancers. So currently, of the GU cancers, there's obviously prostate cancer, bladder cancer, kidney cancer, that there are ongoing programs with immunotherapy. And there's one approved agent, that is sipuleucel-T for prostate cancer. There's also several others that are in phase 3 clinical testing that we can share with you some data on. There's also checkpoint inhibitor studies going on in bladder cancer and in kidney cancer, and I'm certainly happy to talk about those. What I had was just a few slides to go through, but what I wanted to do in this more intimate setting is have more time for you to ask me questions, and we can go back and forth. So first of all, let's talk about sipuleucel-T, or Provenge. This is the therapeutic vaccine approved for prostate cancer. So this is how it is made. So you take a patient here, they undergo apheresis, and this basically is, they hook you up to a machine that takes out your blood, separates out the white blood cells, and gives you back the rest of your blood, and takes those white blood cells, you send it by overnight to a central processing facility. It is processed there. The vaccine is made there. Basically, what they do is they take a fusion protein that has a target for the cancer, and this target is called prostatic acid phosphatase. That is also fused with a immune stimulator called GM-CSF, or granulocyte monocyte colony stimulating factor. This fusion protein that is put in the white blood cells there, the antigen presenting cell enriched population, and that is allowed to culture together, and then that is sent back after all the lot release criteria are met. That is sent back to the physician's office, that is infused into the patients via IV, via the vein. And that entire process with the apheresis is repeated 3 times over the period of about 1 month for a treatment course with Provenge. And here you can see the timeline. It takes them a couple days to make this, and then by day 3 or 4, it is infused back into the patient. So here is the trial design for the randomized phase 3 trial that was the FDA used for approval of sipuleucel-T. And this is known as the IMPACT trial, or the Immunotherapy Prostate Adenocarcinoma treatment. And they took patients who had metastatic disease, who had been treated with hormonal therapy to bring down the PSA, because hormonal therapy does work well, but it only works for a period of time. And these patients had progressed despite the hormonal therapy. They hadn't had chemotherapy yet. So this is a patient population that really, at that point, really was in need of new agents that could improve outcomes for the patients. It randomized patients to receive the sipuleucel-T versus a placebo, basically patients who had apheresis but didn't have this GM-CSF PAP fusion protein added to their product. And then looked at progression-free survival, but the primary endpoint in the study was overall survival. And so there was no improvement in progression-free survival. We'll come back to that in a little bit. But there was improvement in overall survival, which is obviously more important anyway for patients. And so there was actually a 4.1 month improvement in survival, a 22% reduction in the risk of death from any cause. And so based on this data, the FDA approved sipuleucel-T. And if you've seen curves like this before, basically this is at the beginning of the trial. 100% of the patients are alive, obviously. And then over time, you see some patients die early, and then there's other patients that live a longer period of time. This is actually a nice difference between the curves. It doesn't look like much, but for cancer studies, it is an incremental advance, but we're used to seeing even smaller curves than that. Smaller differences between the curves, I should say. So there are many different therapies approved for metastatic prostate cancer. You can see here based on phase 3 data, and many of these have been approved in the last 5 years, which is really, I think, been a good advance for us. You can see chemotherapy, originally approved about 11 years ago, shows a 24% reduction in the risk of death, a 2.4-month improvement in overall survival. You can see sipuleucel-T, or Provenge, 4.1-month improvement in survival, 22% reduction in the risk of death. And this is probably the best column to look at in terms of the reduction in the risk of death, because that goes over the entire length of the curve, just not the middle number. And then there's another vaccine here that is in phase 3 testing that we've tested at the National Cancer Institute also. Again, not definitive data, it's only phase 2 data, but you see a nice reduction in the risk of death and an improvement in survival. But the nice thing, I think, with both of these vaccines compared with the standard of care treatments is very little in terms of side effects. You rarely have to stop a patient getting treatment because of side effects compared with chemotherapy drugs. So patients don't get sick with these treatments, and I think that, to me, is important, especially if you are seeing the improvement in survival. But I want to point out one other thing, and that is, whereas with these other agents you're seeing nice decreases in tumor markers, you really don't see much difference in tumor markers with these therapeutic vaccines. So based on the data that we've seen with the PSA Tricom or ProstVac vaccine that's in the phase 2 setting, there is a randomized phase 3 trial that's ongoing. And this trial is taking patients and giving them this vaccine up front with this GM-CSF, which again is the same protein that helps stimulate the immune system that is used in the Provenge vaccine, the sipuleucel-T vaccine, or just the vaccine alone without the GM-CSF, or a placebo vaccine. And what the primary endpoint of this study is overall survival. I'm happy to report that we completed enrollment in that study in January of this year, and hopefully we'll have data next year. And if that data is positive, it will lead to its approval. So question that comes up frequently is, what happens if you use these immunotherapies earlier? Isn't it going to be easier when you have lower burden of disease for the immune system to get engaged? And doesn't it happen that as you have a higher level of tumor, there's more immune regulatory components so that they will dampen an immune response? And indeed, that is true. So let's look at what data we have for this. So we have come up with this growth rates hypothesis that can explain how you're getting improvement in overall survival, but you're not getting improvement in progression-free survival, as I mentioned earlier. And so what we're seeing here is this slowing down in the growth rate over time when you give the immunotherapy, like sipuleucel-T or like Provenge. And what happens, though, if you start the treatment earlier on? Could that lead to improved outcomes of patients compared to later on? So there is data from the IMPACT trial of sipuleucel-T that really suggests perhaps using this earlier is better. Let me walk you through that data real quickly here. So what they did was they did something really interesting. This was a retrospective study, so this was not something that they thought of before, but it was something that as they were teasing apart the data, they saw, and based on some of the data that we had done, it really made a lot of sense. So what they did was they divided up the patients into 4 groups based on their PSA when they came on study. PSA is a pretty good marker of disease, and if the PSA is going up, it's a bad thing. If it's going down, it's a good thing. So they divided them up into very low PSA, a little bit higher, and then the high. And you can see here that about 128 patients in each group, and the PSA baselines here less than 22, again, metastatic disease, 22 to 50, 50 to 134, and greater than 134. What they found was that if you got treated with sipuleucel-T or the Provenge, you had a 41-month overall survival. Really pretty good for prostate cancer. If you were treated with a control and you had a PSA of less than or equal to 22.1, your overall survival median was 28 months. So that was a 13-month improvement in overall survival, whereas overall there was a 4.1-month improvement. So this suggests that treating earlier on may lead to improved outcomes. And again, you look at the hazard ratio, perhaps the best thing, because that measures across the entire curve, not just right at the middle point, and you see there's a 49% reduction in the risk of death compared with 22 in the whole trial. And you can see that as your PSA goes up higher and higher, indicating a bigger burden of disease, the effect size goes down. So the amount in the highest group, you're only getting a 2.8-month improvement in survival associated with a 16% improvement in risk of death. So what I wanted to emphasize here then is that sipuleucel-T is an approved therapy for metastatic castration-resistant prostate cancer. There are several other agents that are showing promise in prostate cancer and in other cancers. We didn't talk at all about the immune checkpoint inhibitors in bladder cancer or in kidney cancer, but I'm happy to during the question and answer time period. Perhaps what we're seeing is really not a big difference in progression-free survival, especially for therapeutic vaccines in prostate cancer, and there are many reasons for that. But I think it's important for us to understand what might be going on here so that we can manage expectations of patients and physicians, because we might not see decreases in tumor markers or prolonged progression-free survival, but we still may see improvements in overall survival. So it doesn't mean necessarily that the vaccine or the immunotherapy is not working. And we're seeing that also in immune checkpoint inhibitors, where patients that aren't having objective responses may still be benefiting with prolonged stable disease. And also I showed you data that earlier use of immunotherapy may lead to better outcomes compared with starting immunotherapy later on. And there's good biologic basis for that too. So I think that in the GU space, you are likely to see new agents approved during the next 1 to 5 years that are going to change the standard of care, change the way that we treat patients with cancer. There are multiple phase 3 studies ongoing, and I think those are going to, and these are all single agents. I think there's even additional promise to combine agents down the road, because I want to be able to not just move the escape and the 3 E's back to equilibrium, but to elimination. Thank you, and I'd certainly be happy to answer any questions you have.